We are going to learn about communication part 1. This will be taken by Miss Mukta Dhavalikar, who is a registered clinical psychologist and completed her MPhil in clinical psychology from Amrita Institute of Medical Science. And since last 3 years, she is working as a consultant clinical psychologist at Dilasa Center for Palliative Care. So she has more experience in palliative care, and so she is the apt person to talk on communication with this. Welcome and over to you.
Hello, ma'am. Thank you so much. I'm keeping my video off because of some network issues here due to rains.
Okay. Thank you.
In case my voice starts breaking or something, just let me know in the chat box or like unmute and tell me. Yes. Okay.
Sure.
Thank you. Okay. So can we start? Anup, can we have the PPT, please?
Yes, ma'am.
Yeah.
Is it visible?
Yes. Yes. Yeah. Thank you. Next slide. Yeah. Okay. Okay, so first of all, I gather that today we have all nurses over here and we're going to talk about communication. So, can anybody tell me why we are talking about communication? Why is it important? Do you think it's important as nurses to be able to communicate? You can type in the chat box, you can unmute and tell me. Okay, somebody saying yes. Okay, let's see first of all why it's important. Okay. Can anybody share one good memory that you have of meeting a healthcare professional? It can be a nurse, it can be, keep aside your professions as of now. It might be in your childhood or even later. One good memory that you have of meeting a doctor or a nurse or any other medical professional as a patient or as a caregiver of a patient. Or you can also tell me a bad memory that you had. Anything is fine. Anyone? Has anyone had a good or a bad memory with somebody in the medical profession? Please speak, please communicate, because this is not going to be a one-way communication. I also want to hear from you about what you all think about this. So let us discuss.
Nurses, please share your thoughts. Please share your experience.
Yes, I have, ma'am.
Okay.
I am a sister and working in a Maharashtra village. Then I was working. Then one day, one villagers came and told me about a lady is bedridden. And please go and see. So myself and my colleague, when gone to that house, then we saw the lady was full of these worms, and she was only screaming. Then I went and we went and met the patient, and we saw this leg was with ulcer, and it was full of maggots. And we cleaned and we did so many things, and we gave bath to her, and we cut her hair, and we cleaned that house. And after that, we saw that made one cup of tea and little biscuit, and we gave to her. and she was little bit talking. Then she told that thanks, and we want to shift her to hospital. Then we have to get permission because she was alone. Her children were kept her aside, and they were not looking after. So we went and met the police of that village, and we called them, and the police officers told that we also will come and join with you. And we together went to that house again, and we were planning to take her to the hospital. But unfortunately, when we when we went to that house, she was in a gasping stage, and we sat there and we prayed for her. After half an hour, she breathed her last. And the and the villagers together gave her the burial. And we were so happy to see that, because villagers were not looking after her. When we took the initiative, the villagers also came to help us. That was a touching moment for me to do the care for the sick.
Okay, sister, that's definitely a very, excellent work that you all did there. And I'm
Thank you,
sure
ma'am.
that you gave her a good memory of meeting a healthcare practitioner. But my question is basically, when you were a patient, or when you were a patient, like, your relative was a patient, and you went to meet a doctor or a nurse.
Okay.
Yeah, I want to know one good memory that you have of me, like being a patient and when you met a doctor and how that doctor treated you, or a bad memory that you have with a doctor. Can anyone share? Okay, let us go forward. I think it will be more clear what I'm trying to say as we go forward. So generally, if you think of, even if you haven't shared, okay, you might have in your mind some memory that you had as a child, or when you were small, when you had gone to a doctor and a doctor was nice to you, or when a doctor was very rude, right? So generally, good memories are with medical professionals who looked at us as fellow human beings, who spoke with us with genuine care and concern and respect, right? Like sister was telling how she treated this patient with concern, with genuine care, and with respect, right? So generally, your good memories as patients will be with professionals who have treated us with respect, who did not look down upon us, who did not treat us from a high chair, right? And it's also not just about being in a patient's good books. Communication is also about treatment. So it is about getting to know the patient's needs, right? And also the patient's right to know about their condition, to have clarity about what are my treatment options, what is my doctor going to do, what are the nurses doing right now, what medicines are they giving me, what is the prognosis, right? So about the professional to asking doubts. So there are so many studies which show that there is a major unmet communication need for information about the disease, prognosis, and treatment options. Okay, so basically, our patients don't really know. It's not communicated to them about what is their disease exactly, what is their prognosis, what are the treatment options, along with the side effects and complications that can come up. Basically, what this tells us is we avoid difficult conversations, right? Uh, Next slide. Yeah. So basically, why do we need good clinical communication? Because it will enable our patients to express their needs easily and efficiently, right? They will be able to clarify their doubts, whatever, if they have some baseless assumptions, we will be able to tell them that what is the truth and what is not, what are myths, right? So that will definitely happen if there is good communication with our patients. With good communication, we will be able to build a rapport which will aid treatment adherence. It will help the patient and their families deal better with their emotional response to the illness and the uncertainty. So, the anxiety that they face, the depression, the sadness, the fear, whatever that they are emotionally undergoing, if we have good communication with them, we will be able to support them in feeling better. Thirdly, it will help us. How will it help us? If our patient is communicating nicely, clearly, we will be better able to understand the symptoms, how these symptoms are changing, how is that change impacting the patient's quality of life. So, simply put, we will start seeing clearly exactly where the patient stands physically, mentally, emotionally, and spiritually, which is what we are doing in palliative care, right? So, we are trying to look after their physical, mental, emotional, and spiritual well being. So, we will get a very clear picture of the clinical condition of that patient. It can help us better understand what the patient's thought process is, what meanings are they attaching to their situations. Through good communication, we can convey the required information about the disease or the plan of care to the patient in a manner which will help them feel supported and which will help them understand what's happening. Also, one important thing is long-term clinical relationships. For example, in degenerative diseases, in terminal illnesses, where we see patients for a long time. Okay. So these long-term clinical relationships, which sometimes go on for years, are sustained on trust, right? So only if my patient is trusting me, then they'll speak openly, right? And communication helps build trust. So you already know that the patient, their family, and members of the treating team are all equal participants in the treatment process. And when there is mutual trust among members of this team, only then we can have rational and shared decisions about treatment. Because the patient is then more likely to complete whatever plan is being prescribed and to adopt more health promoting behaviors, right? And basically, that will lead to a balanced decision, which is based on what the clinical team thinks is right, as well as what the patient's values and beliefs and priorities are. So it's not we taking the decision for them. All right. Um, okay. Next slide. Okay. Let me tell you a story here. This is actually coincidentally a patient that I'm currently dealing with. It's a case of kidney failure. And the crux of this case has been communication. So I thought that nothing better than this to illustrate how communication is important and how important it is in our work, right? So this is a 37-year-old lady who lives in a nuclear family. It's just her, her husband, and her child. She's educated up to 10th standard. Her husband and her 11-year-old son live on a farm, and her husband works there at the farm as a caretaker of that farm. And she's unable to understand English. She follows Hindi, but not very fluent at it. She understands Konkani, which is the native language. Now, given their socio-economic condition, lack of literacy, lack of exposure to cities, etc., the husband is also hesitant when it comes to big institutions, big hospitals, where he feels he won't be entertained, or he will ask some obvious questions and end up looking like a fool, or he won't understand what the doctor is telling him anyways. That is his issue. And they have never had to go to such a place also because they were quite fit until now. Whatever little minor health issues they have had, they managed with the primary health center in the village itself. But now, out of the blue, this lady was diagnosed with a shocking case of kidney failure. The reason being unclear. Now, when she went to the PHC with complaints of tiredness, swelling of feet, what they did was they didn't tell her anything. Okay, they didn't want to deliver the news. So they kept mum, but they asked her to rush and do some tests. And they urgently sent her to the big government hospital in the capital city, which is around 3 hours from their village. Okay, and they asked them to rush there urgently. Now, what happened? The owner of the farm, okay, this person's boss, he took matters in his own hand and he accompanied them to a specialist. He was like, let's go to a good doctor, took them to a specialist. This specialist did not speak the regional language, right? He was from outside, he was not from the state. So, what and directed at the patient's boss because he would understand. Now, the husband, who was anyways intimidated by the setup and the doctor and the reports, started pushing his boss only ahead whenever it was time for discussion with the doctor, assuming that if he goes all by himself, he will either misunderstand or panic. So he would always push ahead his boss and say that, no, you only talk to the doctor. And the patient was not told anything about the diagnosis except that her kidney was not functioning properly. Okay. And her treatment began. They started giving her medicines, but there were no results. When they went to the doctor with the reports, he just turned to the couple and said curtly that next time you get your parents, they have to give you a kidney. Okay. That is what he said. And the patient found this to be very rude and very insensitive. And she got scared, of course, and angry. And she refused to visit him again. And she was taken to a different doctor who also did not communicate directly with her, but was not rude at least. And the husband, with his prime defense mechanism of avoidance, he got her everything. Her husband got her medicines, good food, everything. But he never spoke to her about her illness, except getting angry at her when she was not taking her medicines properly. And he also complained to his boss, the owner of the farm, that his wife is not taking medicines. And so this boss of theirs, he contacted me for a consultation. That is how I met this person. Okay. Now, based on what we know about S, do we all agree that what was happening till now was poor communication? Yes or no? Going to the PHC, them just sending them to do some tests without telling them why, the doctor not communicating with the patient. Yes? Okay. Uh, Someone is saying yes. Okay. Yes, so we agree that, okay, this was poor communication. Why? Because there was lack of respect. There was no explaining. Even at home, there was avoidance of the topic. They themselves, the husband and wife, were not talking about it. So there was lack of communication within the family also. What were the consequences of this? Okay, what happened because of lack of communication? Next slide, please. In general, next one. In general, what can happen if there is poor communication? It can lead to poor symptom control. Why? Because the patient may not comply with the plan of care. Like here, she was not taking her medicines, right? Why? Because the patient's needs, patient's concerns were not discussed, were not addressed, right? So that can definitely happen. Another thing that can happen is there is poor adjustment to the illness and interventions, which can lead to worsened distress. Okay. Just like here, she was confused, she was scared because of the uncertainty. Conflicts can escalate. Like, as found the doctor rude and she refused to go to her, or her husband started getting angry at her for not taking the medicines. Now, all of this began because initially there was no communication in the first place. So, conflicts can happen, fights can take place. It can impact the therapeutic relationship also. So, for example, a team which is not communicating effectively, nurses and doctors not talking to the patient properly, may find that if a patient starts asking doubts, we might feel that this patient is too demanding, okay, which can impact the therapeutic relationship. And of course, medico legal problems primarily will stem from poor communication, misperceptions, and misunderstandings that come out of poor communication. So, did we see any of this in her case? Of course, we did, right? Most of these things were there. Next slide. So basically, now we know that something positive comes out of good communication, and there are negative consequences of poor communication. Now, there are some people who feel that they are good communicators because they're quite sociable, they like to talk, yeah, but that's not enough. Just being able to hold conversations is not good communication. One-sided communication is not good communication. right? So let's first understand what is not communication skill. Okay, so if we feel that, okay, because I'm doing this, I'm good at communication, we will be, able to see clearly that no, we need something more. So only conversation is not necessarily adequate communication. I might be able to have a good conversation on general topics, travel, politics, weather. That's not adequate clinical communication. We need to be able to help the patient or communicate about the disease condition and the prognosis, etc., to the patient in a way that the patient understands. That is what we have, what we call good communication, right? If we are just trying to convince the patient to follow an agenda which we have decided as a clinical team, is again not good communication. We are dismissing what they feel about it, right? And thirdly, if we are only conversing in a very soothing, gentle manner, but without allowing for their participation, is again not good communication, right? Next slide. Now, one very important thing we need to understand is communication skills are not inborn. Okay, nobody is born with these. But that also brings me to a good news that because it's not inborn, that means we can all learn it and we can keep getting better at it. And yet we don't do it. We don't learn communication and we don't try to make ourselves better at it. Why not? What stops us and what stops our patients from being better communicators? There are definitely possible barriers that may hinder professionals, may it be nurses, may it be doctors, may it be social workers, or anyone else. And this is something I think we can all relate to, and we would have all had times when we felt this. Next slide. Yeah. So that maybe sometimes we feel like we're too busy to spend time to understand patients' feelings and thoughts. We're just busy taking rounds and finishing our daily work. We might be worried about upsetting the patient and handling those reactions. So we just try to soothe and keep them calm. We might sometimes feel that we don't have the knowledge and the skill that's needed to handle these difficult and sensitive topics. So we might be uncomfortable to touch upon these topics. That is definitely there. Uh, we might sometimes be not able to say, I don't know. Yeah. We feel like we have to have all the answers to what the patient is asking. How will I say I don't know? Okay. So that can be a hindrance. So we don't communicate. We also sometimes concentrate only on the physical concerns of the, where in the body do you feel pain, etc., instead of how they are feeling and what they're thinking, because that is definitely much easier. No, we don't have to really deal with their anxiety and their depression. So we just talk superficially about, okay, physically how are you, and that's it. Sometimes we might even feel that communication is not a part of our job. Our job is only to give them medicines, to check their vitals, to do whatever, as nurses, whatever we have to do. Like sometimes we might have to clean them up and all those things, even those we are ready to do because that's a part of our job. But communication is not a part of our job. That is what sometimes we might feel. We might be worried that if in case we start talking about these things and there is a worsening of the situation, we might be blamed. So that fear is there somewhere. And sometimes we might not know the language and the dialect, which can definitely be a big barrier. Okay, next slide. Okay, so that is why basically we might not communicate properly or learn to communicate better. But why doesn't the patient communicate? There are also barriers that the patients face. Yes, it's not that they want to communicate and yet they can't. There are definitely some blocks that they also have. One thing is definitely that they might feel that the doctors or the nurses or any other staff which is there in the ward, they are too busy. Okay, so why should I disturb them? Or how do I disturb them? Okay, sometimes it also happens that when we in our work also, if a patient is asking us something, we'll also snap at them and say that, oh, right now I don't have time. You ask me later, or ask the doctor when he comes for rounds, etc., etc. So of course the patients also might hesitate because they feel we are too busy. There is, of course, lack of privacy, especially in wards. There are so many people around. How do I ask maybe some sensitive question that I have. Also feel they also have that person that with the medical team, I can only talk about a physical blood or I'm afraid or all those things. I can only tell if there is something wrong with my body that I feel. Okay. They might fear that they might already have an understanding that something is wrong, and the bad news would be confirmed. I ask, so I don't ask now. That is something that can happen. Also fear that if I raise questions, if I ask doubts, I won't get treatment properly.
Mukta, ma'am, we can't hear
That's
you.
angry. Or what if somebody moves the fan?
Hello?
Hello?
Ma'am,
Yeah, is it
your
better?
voice is constantly breaking.
Okay, just a second. Hello?
Yes, you are audible now.
Okay, yes, thank you. So yeah, I was saying that so patients might have that fear that somebody can get angry if I ask something, or if I start talking about my emotions, I lose control over them. Uh, Also, they might be stumped by medical jargons, technical terms. If we use too much technical terms, too many medical terms, then they might not understand what we are saying. So then they just keep quiet. And of course, there is the authoritative hierarchy of the hospital environment, right? They never have direct access to a doctor. There will always be that hierarchy that they have to go through. So nurses, yes, sometimes they're accessible, sometimes they're busy. So the patient might feel that nobody is there to answer my doubts. Okay. So you might also notice that so many of these things were also present in the patient that we just discussed. My patient S. Okay. Next slide. So we saw that, okay, why do people not, why don't they communicate? Why don't we communicate? What are the blocks which we have, right? So let's now talk about what are these communication skills that we have been talking about for so long. So before that, I just want to tell you why I told about the barriers to communication before I started on the communication skills. Mainly because if we, however many skills we learn, we will still not be able to have good clinical communication if we don't know what blocks can come in that communication, right? So we need to know what are the blocks first, so that if we see them, we will identify and we can change those or remove those. So then what are these communication skills? Communication is basically what we hear what the other person is saying. We take in information, right? Verbal and non-verbal. We are actively, mindfully present when we are listening to them, and we are receptive. And so what we do once we take in the information, we also respond appropriately, again, verbally as well as non-verbally. So here on my slide, you can see what we can call the core principles of good clinical communication. Okay. And you might notice that it really has very little to do with how you use your language, etc., etc., and very much to do with being a good human being. And that is what is required, if you ask me. To be a good communicator, you need to be a good person first. So, what do you need for good communication? You need respect. You need to treat the patient and family with respect. That's essential for a healthy relationship and in turn for good communication. Next thing, what you need is empathy. Empathy is basically the ability to understand another person's feelings by placing ourselves in their place, in their shoes. Yeah. To acknowledge that other person's suffering, to help them build a good relationship with us. It is different from sympathy. What is sympathy? Sympathy is a sense of pity. Yes, and other person might not like that pity. But empathy, yes. Thirdly, trust. If a patient loses trust in you, then you can't help them anymore. Okay? Truth is required to maintain trust. Lies will destroy trust. So, being able to communicate truthfully, honestly, is definitely required. And lastly, unconditional positive regard. What is unconditional positive regard? Basically, not judging the other person, accepting them just the way they are. Whether the patient is good or bad, whether they're thankful to us, whether they're always complaining, grumbling, whether they're angry or happy, are they optimistic or pessimistic? However, the patient, always try to consider that that patient is the most important person in the room. Okay? Don't be judgmental and accept them the way they are. That is unconditional positive regard. Next slide. Okay. Now, looking at the 4 things which I told, okay, respect, empathy, trust, and positive regard, unconditional regard. If your patient says something like this, if they say, I feel really scared, there are so many thoughts, and then I can't sleep. Okay. Which of the 4 responses which I've given underneath shows the core principles of good clinical communication? Which of these do you think is respectful, is empathetic, maintains trust, and shows unconditional positive regard? The first response is, you must not be taking the sleeping pills, isn't it? Second is, oh, don't worry, it'll be all right. Third is, who are you? How did this happen to you at such a young age? And fourth is, it must be so difficult to relax with all these scary thoughts running in your head. Which of these do you feel is the right response? Which shows respect and empathy and trust and positive regard? Does everyone feel that D is the answer? Okay, I see 2 responses which say D is the answer. If everybody feels that D is the answer, that's great. That means whatever I have communicated until now has reached you properly. Yes, okay. Thank you. Thank you so much for the answers. If at all there is confusion, you can always ask me. Okay, great. All right. So, are there any questions so far, or else we will move ahead? Okay, next slide, please. Great. I see that most people are saying D. That's great. Okay. So, let's move a little further into some details of communication. Okay. We all know that there are 2 types of communication. No, there is verbal communication and there is non-verbal communication. Right? So, what is verbal communication? Basically, everything that we express using language or words. That is verbal. Non-verbal is everything which doesn't have words. So, facial expressions, our body language, our gestures, the tone of our voice, all of it. Okay, that is non-verbal. And we all know that communication occurs both verbally also and non-verbally also. But you might be surprised that non-verbal communication is the bulk. Majority of our daily communication is through non-verbal, not through verbal communication. Sometimes, especially in young children and in people who are terminally ill or differently abled or emotionally overwhelmed, non-verbal communication can be the only way to communicate. And also, on top of it, we rely more on non-verbal communication. We trust non-verbal communication more than verbal communication. Okay, so let's say, for example, if I say hi to you with a smile, okay, and if I say hi to you but with a frown, which one will you trust? The first time will you feel I'm welcoming you, or the second time you will feel like I'm welcoming you? First time I say hi with a smile. Second time I say hi, but I do it with a frown on my face. which is more welcoming? Surely with a smile, right? Absolutely, yes, Maria ma'am. Okay, so basically, what does that mean? If there is a discrepancy, if there is a difference between what my words are saying and what my expressions are saying, so what I'm saying verbally and non-verbally, you will trust the non-verbal more than the verbal, right? So we trust what is not said. So it's extremely important for us to pay attention to not only our words, but also what are we communicating non-verbally when we are talking to patients. And we also need to respond to what they are telling us non-verbally. For example, you go to check a patient's vitals and that patient is looking gloomy. And you ask them, how are you? And they say, yes, I'm fine. Okay, but they're looking gloomy. Yes, what would you do? Would you just take their answer on face value? Or would you inquire? Would you say that, but you look down today? Yeah, so acknowledge what you're seeing non-verbally. Acknowledge that they look low, their mood doesn't look good. Let the patient know that you care enough to notice what they're not telling you through words. And just like we speak about the patient's nonverbal communication, we are also communicating through our gestures and our postures, how we sit, how we stand, what is the tone of our speech, right? So we need to be aware of what messages are we sending to our patients non-verbally. Let's say, for example, I'm sitting in front of a patient who's crying. Okay. And here I am thinking, oh, my duty is actually over and I'm going to be late for my kid's school function. And I keep checking my watch. I'm sitting, but I'm very, very restless and I'm fidgety, thinking of how I'm getting late. Will my patient notice this? And will that create a block in the communication that I have with this patient? Of course it will, right? So there are simple things about our body language that will facilitate or help us communicate. Simple things, a genuine smile when you go see a patient, an open posture. How often have you seen doctors in your setups who are looking into computer screens and appear super busy as the patient comes in to see them? And they begin questioning the patient even before looking at the patient once. They're busy looking at their computers, typing. Right? Now, this is something that creates a block. Simple things. Look at the patient, give them a smile, or when talking to children, go down to their eye level, sit down and talk to them. Don't talk to them standing up, looking down at them. These are very simple things, very small things, but they show respect. They communicate that you're genuinely interested in being here with the patient. That is what your patient wants. Let's look at some helpful strategies that you can use when you communicate. Okay. Next slide. Okay. So, what are these? Firstly, open-ended questions. Open-ended questions are your best friend. So, let's say, for example, I ask, are you in pain today? Versus I ask, how are you doing today? Is there a difference? If I ask you, are you in pain? Or I ask you, how are you doing today? Are they the same thing or they're different? The first one, which I asked, okay, are you in pain today? You can only answer in yes. The first is close-ended, right? Only yes or no answers. But if you ask, how are you doing today? The second, you are inviting the patient to open up, to express, to tell you more. Open-ended questions give you more information. It lets the patient tell you what they feel is a priority concern for them. Okay. And that's important for us also, because otherwise, what we didn't inquire about, we might not know, even if it's important to us. Right? So we lose out on information because we didn't ask for it. So always ask open-ended questions to start with. Secondly, Summarize and check for patient's understanding always. Okay, so if you're telling the patient something, is there a difference between what I wanted to tell and what the patient actually understood? Always ask. So it is also useful to summarize whatever you have told, summarize it again. Okay, so there is also not overload for the patient. You give them everything in a nutshell, in a summary in the end. Let's say, for example, you can say something like, I just want to go over what we have been talking about so that we are on the same page. Okay, whenever you're ending, you could say something like, what questions do you have? Is there something you would like to know more about? Do you have any doubts about these medicines? Anything. Okay. And followed by a summary, right? Always say that you will meet them again. And in between, also, if they have any doubts, any questions, they can always note them down and ask them when you meet. Right? So you always summarize, you always check that the patient has understood. That's second. Thirdly, avoid jargon and avoid overload. Jargon is basically technical terms, medical terms. Don't say it in simple language, the way that they will understand. Okay, no heavy technical medical terms. Because our goal is what? That the patient should understand what we're saying. Also, don't give too much information at a time. Give it in chunks, smaller chunks. Okay. Also, encourage them to ask doubts and questions. But at the same time, respect the patient's choice about how much they want to know. It's not compulsory that you tell them everything at once. Okay, especially when they're telling you that they don't want to know at this time or they're not in a state of mind to listen. And of course, most such discussions, especially in the palliative care setting, will have a heavy involvement of an emotional component, right? Make sure that you don't avoid facing them. Be present there mindfully. Okay, don't judge them and listen what they're telling. Acknowledge their feelings. Let them know that it's okay to feel what they feel. That it's okay to be angry. It's okay to be sad. It's okay to be afraid. Yeah, and it's also natural in the context. Don't invalidate. Don't say that there is nothing to be afraid of. Okay? Because there you know that there is something to be afraid of, definitely. So acknowledge their feelings. Let them know that you're validating their feelings, that you're not dismissing them. Be okay with silences. They help. Yeah, if we are uncomfortable with silences, then that's going to be very problematic because when the patient is being silent, if you have told them something and the patient is just sitting there silently, mostly they're taking time to process what you've said. That's important for them. So don't fill the silence with like pointless communication. Okay, because even if you're saying something, the patient is not in a state of mind to hear it or receive it. And if the patient is hearing it, then basically we are just distracting the patient from actually processing their own emotions. Right? So don't interrupt that process. If they're being silent, give them some time to pause. It's okay. Always have that balance between hope and truth, especially when we're delivering bad news. We can always do it sensitively, right? We don't have to either choose hope or truth. We can always find a balance between the two. So we don't necessarily have to say something like, we can't do anything more. There is no cure for your disease. You better go home because there is no point in staying in the hospital now. You'll only waste your money. Okay, that might be true. But you also don't have to believe and you have faith you'll surely recover when you know that that's not going to happen. That is always find a balance between hope and truth. So in such a case, what can you say? Maybe something like, sorry, I'm afraid there is no more treatment available to cure your disease, but we can definitely keep you comfortable with medicines and regular monitoring. We are here for you. Right? So you're not taking away their hope, but you're also being truthful, you're being honest. Maintain confidentiality. If the patient is giving you some sensitive details which they don't want to disclose to anybody else, reassure that whatever they're telling is confidential. Respect boundaries. Respect patients' boundaries about what they want to tell and not tell, what they want to discuss, what they don't want to discuss. And further inquiry is very important. So especially in problem behaviors, no, your patient is not eating, your patient is not talking to anyone, there is social withdrawal, they're not taking medicines. Usually that is not the problem. Usually there is a deeper underlying problem. Okay, so always inquire why they are not eating, why they're not talking to anyone. Always ask why, because there is definitely a reason. Always there is a reason. So to sum all these things up, you start with open-ended questions. You let them lead the way. You speak simply in a way they understand. Validate their feelings. Adhere to the core principles of respect and empathy and all that. And ended by summarizing. Okay, I hope that was clear. Any questions? Anybody has? Okay, all right. We will move ahead. In case there are any questions, you can always put in the chat box because we don't have a little time is remaining, so I'll just move ahead. Okay. Next slide. Okay, we saw what to do, but it's also very important to see what not to do. That's equally important. Okay, so let's also talk about what is a strict no when communicating. Most importantly, don't moralize. Don't give them philosophy. Okay, don't say stuff like this life is a gift by God and stuff like that. Don't moralize. Okay, because then the patient will feel you don't understand them. Okay, they start feeling like you're lecturing them when they are in so much pain. Okay, especially when people talk about not wanting to live, etc. So just be there with them. That's more important. Avoid comparison. Avoid saying stuff like, look at that patient. That patient is in so much pain, but does that patient cry? No, why are you crying so much? There are so many others in a worse condition than you are. Don't compare. Okay, because you never know what that patient is going through. So never compare. Thirdly, don't make meaningless statements which can stop further communication. So what do I mean by meaningless? Saying, for example, there is nothing to be afraid of. You know that it's not right. So don't say that. Don't say something like that because then the patient will feel like, okay, I'm telling them so much, but they don't want to listen. So I'll just keep quiet. Avoid jargon, which I've already said. So let's say, for example, a doctor or a nurse comes and tells me that the carcinoma is radiosensitive. What do I understand? Nothing. I don't know what a carcinoma is. I don't know what is radiosensitive. Okay. So I didn't understand anything. So don't use jargon. Don't give false reassurances. Hmm? Don't make assumptions. Always ask why are they doing something or what made them ask a particular question. So don't assume. Don't be condescending to them. Okay. Don't say stuff like, do you know more than us? Okay. So don't do that. Always give them respect. Don't force your beliefs on the patient. Okay, it might be religious beliefs, spiritual beliefs, or anything else, but don't force them on the patient. Don't show sympathy all the time. Don't be like, oh, poor you. Don't use inappropriate humor. Now, there are some people who just want to, to lighten the atmosphere or something. They'll just crack jokes anywhere. Don't do that, especially when it's not the right time and place to do it. When you know that the patient is in real distress, don't crack jokes about that distress. Okay. Don't be thoughtlessly honest also. It is not just about telling them the truth, it's also about how you tell them and when you tell them. So don't just always have thoughtless honesty, but at the same time, don't lie to them in a way that will break their trust. Okay, be honest, but make sure you're telling things in the right time. So let's just put things in a sequence, okay, so that it's easier to put it into practice. All right. Next slide. Okay, so we can say that these are steps for effective communication, and we can put them to 7 steps. So how do you do it? How do you communicate with your patients? Firstly, you build a relationship. Okay, so you need the time to do that. You need privacy to do that. Preferably sit down at their eye level, but not too close to invade that space, right? So make sure you are being there, spending time with the patient. You convey empathy with your expressions and with your words. For example, saying something like, I see that you're very worried about this. Most importantly, convey that you care. That will help you build a relation with the patient. That's the first thing to do. Then what do? You open up the discussion. You acknowledge their feelings. It could be pain or loss or fear or anything. So when you acknowledge that they are suffering, the patient will feel understood, right? But if you dismiss their emotions, they will feel misunderstood or they will feel like you don't understand at all. So acknowledge. Then you listen actively. What is active listening? You'll give them eye contact. You'll show appropriate facial expressions. Your body language, you'll be leaning towards the patient. There will be verbal responses. You'll say things like, yes, I see, or you'll say, in between, etc. So you'll let them know that you're listening. Okay. And you'll also encourage the patient by maybe repeating the last few words that they said or by paraphrasing. And of course, when you're doing that, when you're actively listening, you listen to their words, but also you look at their facial expressions and body language, which can show you that they're suffering. That's the second thing, the second step. After you build a relationship, you open the discussion with them. Then you gather information. You find out what is the patient understood. What is their level of understanding? What do they know? How much do they want to know? Here you can use open-ended questions. Okay, so you can ask them, what do you think might be the problem? Or what worries you the most? Or that must have come as a shock to you. These things will help. Once you've gathered information about what they know, you understand the patient's perspective. Okay, so what do they feel about this? Let's say they know that a patient knows that they have terminal cancer. What do they feel about it? Do they have questions about it? So be prepared for emotional reactions. So there can be sobbing, anger, silence, despair, hopeless kind of emotional reaction. Be prepared for it. Quiet. Here you will have to prompt a little. You will have to say things like, could you tell me what you are thinking, how you are feeling about this? So that is how you understand the patient's viewpoint. After you have done that, then you start sharing information. Okay. So once you realize what is most important for the patient, then you start speaking and telling them about what you know about it. If they want to not talk about it right now, if they want to postpone that discussion, let's say they want to postpone discussion about the treatment options, allow it in a reasonable time frame. Okay. As I said, the patient has a right to know everything, but it's not a duty that they have to know everything. Let them decide. Use common conversational language when you're sharing information and keep checking the understanding. After which you will reach agreement on problems and plans. So you summarize all the problems that your patient told you. Of course, the doctor would have suggested a course of action. So you talk about that to them. You answer their questions about them. You arrive at a course of action that is acceptable to the patient also. Okay. And you always let them know that these plans are negotiable. They can always tell about their concerns to you or to the doctor. And lastly, you close the discussion and you do it very sensitively. So don't do it abruptly. You review whatever has been spoken, you summarize everything that you spoke, and you leave the door open to talk again. So you let them know that whenever you want to talk about something, you can always call me. Okay. Now, these are basically the 7 steps. All right. Now, is anyone wondering what happened to my S, the patient that I spoke about? I told you half her story, right? I told you what happened and how I met her. I didn't tell you what happened after I met her. So let me just complete that story now. I did exactly these 7 steps that you can see on the screen. This is what I did. I built a rapport with her. I introduced myself and I told her that I had come to speak to her about her illness and to know how she's doing. The moment she realized that I was not there with an agenda, but I was there with genuine concern about how she was coping, she opened up to me. The first thing the lady told me was she had heard the word kidney for the first time in her life. She had no clue what it did. Basically, when the doctor told her kidney is not functioning, it sounded alien to her. She did not understand a word of it. It had no meaning. But when she sensed the seriousness in the atmosphere, right? The way the doctor was speaking. So she came home and with the help of her son, she Googled kidney. Okay. So from Google, of course, she understood a little bit about what it was. Now, people who could communicate the right information, like the doctor, were not talking to her. But there was no shortage of people who gave baseless information, who did not feel how will this impact her, or is this true what I'm telling her. So they just came from WhatsApp University and whatnot, and they started giving her information. So she heard all kinds of stories about how this means she will die, all sorts of scary and tragic stories filled with negativity and filled with despair. So what did she do? She did her best not to listen to them. Okay, what would anyone do if somebody is telling you such scary stories about your health? You wouldn't want to listen, right? So she didn't. So now, in that attempt, what she did was she overcompensated by denying the seriousness of what has happened completely. She was tired of the 30 pills she had to swallow every day. She had tons of questions, no one to answer them, so she stopped. So when I met her and she told me all of this, and I understood how she was feeling and what she was going through, after that, I started talking to her. So we started right at the beginning, okay, with what a kidney is and what it does. Most importantly, that there are two of those, that there are two kidneys for every person, and we can function with one kidney. So basically, her assumption that she's asking her parents to sacrifice their lives for her by asking them to give her their kidney was gone. That was the biggest relief she got from that session. She cried, she let things out, she asked all the questions, she expressed her needs of how that uncertainty was bringing fear, how anxious she was, how worried she was for her son, who had grown up too soon in this entire thing. And she felt that if she knew what was going to happen, what the doctors were doing, she would be much better prepared mentally. So she very clearly knew what she wanted. She wanted clear communication, knowing what had happened to her, knowing what was being done to her, knowing what could happen to her. Simple needs. So at the end of the first session, I did tell her that she was free to get in touch if at all she had any doubts at a later point also, which she did. So after the first consultation, she became much more cheerful. She started expressing more openly to everyone. Communication at home with her husband improved. We began meeting her son periodically. So that was a big load off her shoulders. She began actively working towards treatment. She took the initiative to tell her family about transplant and the related issues, in which she took our help. So she had not done it till then because she didn't know what to tell them. So I met her family along with her and her husband, and we discussed what treatment options were available, what it means, what a kidney transplant means, and all of that. And currently, her father, who himself is in excellent health, has come forward as a donor after discussions within the family. S is taking her medications. She is undergoing dialysis whenever it's asked for. And she's doing all of this with courage and hope in her heart. S is just fine. And all it took was a few sessions of clear communication about what is happening with her. Yes, any questions until now? I think we've also reached the end of time for the session. So if there are any questions, you can always ask. And I hope it was not boring, that you got to learn something new. Anyone? Any feedback, anything that you want to tell me about the session?
Anyone have any questions, please go on.
Nurses, please respond your comments or feedback about the session. Anything you want to contribute?
Yeah, any questions or anything also you can always ask. I'm hoping that if there are no questions, that means you have understood whatever we discussed.
Any questions? Thank you, Mukta, for the detailed presentation. So we can wait for another 5 minutes for questions, and then we can go on the case presentation.
Sure.
I'm sure you have a lot of questions because nurses are spending more time with the patients. Definitely you will have questions. Please ask. Thank you. So no questions. So before moving on to the case presentation, I would like to highlight few things from today's session. We have learned about basic communication skills, which is very important in everywhere, but especially in palliative care. Usually, as I discussed earlier, so nurses are spending more time with the patient, and we are the most trusted member in the healthcare team. So the nurses play an essential nursing role because we are the persons for advocating and implementing the patient wishes and preference and communicate with the patient and the families. So the basic communication skills is the major role in palliative care. And also when we deal with the patient, the problems while we communicate. So from today's session, you understand that what are the verbal and non-verbal expressions. So the more non-verbal expression we used to use while we communicate. That is very, very important. We have to keep it in mind while we communicate, because our facial expressions and tone of voice and that lack of eye contact, these all will be affecting the patient emotionally. If you are the good, if you want to do the good communication, please keep all the do's and don'ts in your mind. And also, active listening is one of the key successful communication. So this is very, very important. Wherever possible, you have to be a good listener. So ask open-ended questions instead of leading questions or closed questions. If you ask something, that leading questions, closed question, so you're paying better, isn't it? This is a closed question, so they will say yes or no. So instead of that, you have to ask, how are you feeling today? How are you today? Just ask few open-ended questions. Then they will start speak. So, and also in between, you will give some pause, and then you have to contribute something from your side, and also so that they will be understanding, okay, you are the good listener, you are be with the patient, and you are the only person to listen their that problems actively. That all things they should. So these all things you have to be keep it in mind, and also that non-verbal things she has mentioned a lot. So I don't want to repeat all those things. So the active listening is one of the most important part in communication. Wherever possible, you have to be a good listener. So, and also you have to be keep it in mind what the do's and the don'ts, and also don't give a false hope, don't give a premature reassurance. These all things you have to be keep it in mind. So wherever possible, you have to be listen and identify the problems and explore their the problems, and if you are not able to manage that problems, try to include a medical social worker or a psychologist into the patient care, so that we can able to explore more and improve the quality of life of the patients. If you are able to explore it, definitely we will try to manage some way. So if you are not able to, definitely the patient will have that kind of problem. So from the last week, we have learned about the total pain concept. So whenever you have seen a patient, you have to look into the 4 aspects: physical, social, emotional, and spiritual. So if they have a psychosocial issues there, you have to explore well. So if you want to explore their psychosocial issues, you need a good communication skills. Thank you. I think we can, do you want to add anything, Mukta? I think we can move on to the case presentation part.
Yes, ma'am. Nothing to add. I think this was a perfect summing up of everything. Yes.
Okay, we can move on to the patient story. Sister Maria, over to you.
Yes, I'm here. Good evening once again to everyone. So I take you today to my case study. My patient is a male patient, 74 years old. He was diagnosed with CA urinary bladder. Presenting complaints, he came with the complaints of pain in the sacral region with hematuria and generalized weakness. History of the illness: 73 years old male, known case of hypertension on medication, history of tobacco intake 40 to 50 years back. He left tobacco since 1 year, was evaluated outside for complaints of hematuria in February 2022. Then CT KUB was done on March 2022, and which showed 3.8 into 3.3 into 4.2 centimeters lesion in right anterior lateral wall of bladder with associated wall thickening along rig aspect involving right VU junction causing proximal mild HUN. 2.5 into 1.5 into 1.5 centimeter lesion arising from posterior lateral wall of bladder. Was started on tab silidone for 4 mg HS and tab Ditor 5 mg OD. No other management he underwent through except he underwent TUR, transurethral resuscitation of bladder tumor with and was biopsy.
Maria ma'am? Maria ma'am, we can't hear you.
Yeah, I got it in between suddenly. Can I
It's
have the
okay.
screen? I'm unable to see.
You can continue now.
Yeah, sorry, there was a disconnection there. And so it was biopsy had shown high grade papillary carcinoma. He was advised resection again, but counseled about recurrence and need for resection as per patient relative. So he took only Ayurvedic treatment. And then later again, he did a CT KUB in August 2022. And there it was found multiple polypoidal lesions in bladder, largest 5.1 into 3.8 centimeter involving of right VU junction with extension. On examination, his mental status, he was normal, oriented to time, place, and person. Attitudes and moods and affects, he was a calm and quiet person, a serene man. General appearance, body build, he is thin, posture, sitting and supine position in bed, gait is weak. Hygiene and grooming, maintaining, but needs support to do his ALDs. His height 155 centimeters, weight 47 kg, vitals were stable. Temperature 96, pulse 68 per minute, respiration 20 per minute, blood pressure was 170 mmHg. Significant investigations. This investigation was done when he was with us. Only the blood test. Histopath, as I told you already, positive tumor cells, PET scan, adrenal neoplasm, and CBC, RFT, LFT. HB hemoglobin was 9.5, RBCs was 4.49, WBC was 11. All were within normal limit except his hemoglobin was on the lower side, 9.5. And his albumin and sodium is 125, which is again low. Bilirubin was 0.24, protein was 6.2, and albumin was 3. So most of his values were on the low side. Next. Again, creatinine and chlorides also were low. Creatinine 0.64, chloride was 91, blood urea nitrogen was 9, and creatinine ratio was 14.06. Next, please. Psychosocial aspects. Yes, as I have said, he is 75 years old male living with his 59 years old wife. She was a housewife and had 3 children, 2 daughters and 1 son, all are studying. Patient was working in PWD and staying in rented house. Children are studying and managing financially with the patient's pension. So whatever the patient's pension they get, they were managing financially the studies and the family. Patient had a habit of chewing tobacco for the last 40 to 45 years, but he has left it now at the time of admission 1 year back. Next, please. Okay. Medication with us, he was on medication tab gabapentin 110 and tranexamic acid. That was because he was bleeding, and pantoprazole, that is because of antacid. Next slide, please. Sucralfate, again, because it is an antacid, and also because we would want to prevent it with any ulcers. And tolvaptan, because his sodium was low, so to increase his sodium concentration to free water clearance. His main concerns were pain in sacral region, hematuria. He was with anemia because he was having hematuria, so he was he was losing blood, and having generalized weakness. Summary. So he is a 70 years old male with hypertension, with CA urinary bladder, TURBT done, not taken any active treatment, took Ayurvedic treatment, and then again did the CT scan in August. Then multiple polypoidal lesions in bladder, largest 5.1 into 3.8 centimeters, involvement of right vulvar urinary junction with extension. So points for discussion. What is the palliative care provided for this patient? And what could be done more for this patient and their family?
Thank you, Sister Maria, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So I think this case presentation is clear to everyone. We can move on to the discussion points. I would like to ask one question. So she, from your patient story, I understand was a 78-year-old man diagnosed with CA bladder, took an Ayurvedic treatment. Now that he has not done any active treatment. So
only TURBT he did, and that was for biopsy, for the sake of biopsy.
So now he is on Ayurvedic treatment or allopathic treatment?
No, nothing. When he came to us, he had taken Ayurvedic treatment, and then when he came to us, before that he had done that repeat CT scan KUB, and then had found the tumor has increased. So he came with us with generalized weakness and hematuria. So when he came to us, he was in fact not taking anything. So we started him on all this treatment, what I have read just now.
Okay. So how do you communicate with these things to him? So because when he come to you again, so how do you communicate? So this is the communication session. So we will talk on communication part today. So we would like to hear from you about communication. So how do you communicate? After the Ayurvedic treatment, he came to you, no?
Yeah,
So
yeah.
how do you,
Actually, at the time of he came to us as he's a new admission for us. So when he came to us, he and his family narrated that this is what was done. So our first approach was not to judge him, neither to question him why the treatment was not taken, but was only our main concern was to support him. So when he was admitted with us, So we tried to make him and his family more comfortable. And since ours is a family model, so we were trying to not only support him, but his family as well, supporting his wife. I personally was talking to his wife. So his wife was the caretaker. The decision maker was sometimes the children, sometimes the patient himself. But I was more of in touch with his wife. And since we have a very good team, multidisciplinary team, our social workers were very active in explaining to him, and he was aware of the prognosis and the diagnosis and the prognosis, he and his entire family. So it was easy for us to get into them, being with them. It was more of supportive treatment that we could have with him. He and his family, his wife, and he was very open because he was able to understand what is going to him next. Yeah, for sometimes because of hematuria, he was getting little affected, because we could not do catheterization also for him, because it would again increase his complications. So yeah, he was mostly bedridden. Earlier, he used to move out of the bed, then he became wheelchair bound and then bed bound. And yeah, mostly we could do is supportive treatment. Breaking of the bad news, BBN also was done by, along with the multidisciplinary team, doctors, the social worker, and the nurse.
Okay, thank you, Sister Maria. You did well. So that's why I am asking to you, so that others can also understand how do you manage that situations. Usually, what we do, you have to be think. We will blame. Usually, we will start to blame others. So why did you go there? Why did you take Ayurvedic treatment? So you should take allopathic treatment. So why did you there? Now what happened? So just think that kind of questions will be there all the times. Mukta, what do you think?
Yes, ma'am. It's the same thing. Like usually our instant response will be to blame them and to make them feel even more hopeless. Like, saying things like, oh, see, now everything is worsened. Now what can we do? Saying things like that can make the person feel completely hopeless, and that can worsen the emotional situation, even in the family. So just like what I think they have handled the case very excellently. And what ma'am you said also, like being supportive at the time, helping them understand that okay, we understand why you were so desperate and you wanted to give the best, but right now this is the situation. What can we do in this situation? And then take it forward. And being emotionally mainly the support that's required when they hear that bad news that okay, things have worsened now.
Thank you, Mukta.
Anybody else who has any different
Yes.
views about this? Yeah. Any other participant who would want to add something or wants to say something about the case?
So we would like to hear from you all. Please respond. Please give some suggestion. Do you agree with these, or is there any different suggestions? Hema? Hema, Joshna, are you there? Any other different opinion? So any other suggestions or anything? Ashwati ma'am said educational support. To whom? For her, for his children. So what about Sister Maria? Their children's education, is there any difficulty? Sister Maria? So they are asking about the educational support, educational rehabilitation of the patient. So the patient's children. So if they, do you need any help we need to provide? Do you think?
Usually we do, but this sincerely speaking, this educational support and the social support is usually being seen in our center by medical social workers. Sincerely speaking, I didn't go deeper into that, but then yeah, we were concerned about them because they were all three children were working, and the source of income was only his pension that they were surviving, and then they were studying. So I did not go deeply into whether they were given or we have thought of giving the support, but we do provide. Once they express themselves, we do provide.
Okay, thank you. So here also in Parliament also, if our team found some these kind of educational these kind of issues, like especially that occasional rehabilitation, educational rehabilitation, usually we try to include a medical social worker in the team, and the medical social worker will go there and explore more about the socio-economic details, and then after that we have a team that rehabilitation team. We work together, and so if they have all set a criteria for that. So if they comes under that particular criteria, so they will get a educational support. If not, they will not get. So usually our team will decide, including doctor, nurse, social officers, and volunteers also. If there is a community volunteers there, they can also involved in that discussion, and that particular group will decide whether we can be able to give education support to that patient or not.
Yeah, we do have that PSP, patient support program. So again, suppose the patient is with us, maybe the IPD team would decide in what way we can help. Once the patient gets discharged, the patient gets automatically taken up by the home care team. So over there, the home care team, who consisting of nurse, doctor, and the social worker, they will decide if there is any need to reach out to them.
Yeah.
And so there are very many cases wherein even the ration support is being provided.
So yeah, one important thing you have to keep it in mind is a teamwork. So if you identify any problems, so if you are not able to manage it, you have to try to include the team members into the patient care, so that we can able to give a total care.
Yes.
So time up. Mukta, you want to add any last point? Anything you want to add, you can. Otherwise, we can wind up. Mukta, can you hear me?
Yeah.
So
I think I lost network in between. Yeah.
Anything you want to add or want to give some conclusion points, last minute point, you can. Otherwise, we can wind up.
Okay. Yeah, I think we can wind up.
So we have another session.
And it was actually very good to see that what sister said, that they have a multidisciplinary team. It's very good to see that there is this facility and
yes.
very few centers.
Yeah. So
yeah.
Good. So okay, we can wind up the session. Anyway, the next session is on communicating bad news. So is connection with this session, that session will be there. So we will do the recap and go for the communicating break news part next week. So anyway, thank you, Mukta, for the wonderful session. Thank you, Sister Maria, for the excellent patient story, and that you have managed well, that all things is encouraging all the participants, and we also learned here these kind of the teams and NGOs, that palliative care centers are there in the other the states also. That is also the important things which we heard here today. So thank you once again. Thank you all for your participation. Thank you. We'll see you coming Thursday. Thank you.